School and Internal Medicine residency at the University of Utah in 2002 and his GI fellowship at the University of Iowa in 2005. His specialty interests are the management of patients with inflammatory bowel disease, functional gastrointestinal disorders, and liver disease. When not at work, he enjoys skiing, camping, traveling, and photography.
You do that. Okay. Well, I have to give everybody credit for making it through a long day and sticking around to hear this last talk. I may not be able to stand right here because I can barely see over this podium and see my slides. So maybe a show of hands of people here who have taken care of a patient with C. difficile in the last 30 days. Okay, so it lasts 90 days. And we pick up some more people. So I think this is a particularly important topic for a lot of us, and a topic, a problem that I deal with every day in clinical practice, and a problem that I was called about and texted about not more than 3 hours ago, about a patient of mine with multiply recurrent C. difficile and how to manage this. And so if I can figure out this as well, there we go. So disclosures, I am a speaking, I speak for Takeda Pharmaceuticals and Abbott. I will be talking about the off-labeled use of antibiotics for treatment of C. difficile in addition to those that are on-label, FDA approved, and fecal microbiome transplant, which is not FDA approved. And there are no other really financial disclosures that are important for this. So let me start with a case that I had. This is a 63-year-old woman with poorly controlled diabetes, chronic renal insufficiency, morbid obesity, and severe active coronary artery disease, who had been treated with antibiotics for cellulitis and had developed diarrhea for 3 weeks, and presented to the emergency room after 3 weeks with 15 to 25 bowel movements a day, increasing dehydration, and she became lethargic and confused, and family had called the ambulance. So a really, really very sick patient just from that history. So admitted to the IMC at 8 o'clock in the morning, febrile, blood pressure wasn't too low, she was tachycardic, white count was high, lactate was increasing, diffuse abdominal tenderness, increasing confusion, lethargy, and then had this x-ray, or an x-ray very representative, that showed a very dilated colon. So from the history, we suspected that she had C. diff. They called me and said, well, is there any way, and the surgeon was very nervous to take her to surgery because of her comorbid disease. She was a very, very sick person. That you could just confirm that we think this is C. diff. I said, well, sure, I can just put a scope in and, unsedated, unprepped colonoscopy. We didn't have stool culture or toxin back. And this is a picture representative of exactly what I saw. Up on the right corner is pseudomembranous colitis. So I let the surgeon know that this appears to be pseudomembranous colitis, no question about it. She had a talk with family and the patient. Patient was deteriorating very rapidly. They decided that her operative risk was so high that we would treat medically and conservatively. Well, she deteriorated very rapidly over the next few hours and was made DNR and DNI and died later that evening from C. difficile. And so wanted to talk about that today, and objectives for this talk are to discuss the history, epidemiology, why this is such a growing problem worldwide, clinical features, diagnosis, drug and non-drug management, and lastly, the role of fecal microbiome transplant in difficult cases of multiply recurrent C. difficile. So a little bit of background, Clostridum difficile is an anaerobic gram-positive rod, unique because it forms spores that can survive for long periods of time on surfaces. These spores are resistant to heat, acid, antibiotics. In the right setting, these spores can become vegetative, Clostridum, and elaborate toxin that can cause symptoms, very, very bad symptoms. So some milestones and important dates in the history of C. difficile. The first reported case, we believe, 1892. found in the bulletin of the Johns Hopkins Hospital. John Finney. Anyone heard of the Finney pyloroplasty? So he was doing just that on a patient in her 20s that came in with severe abdominal pain and weight loss and was near death. Found to have a big gastric and pyloric ulcer and underwent a pyloroplasty type procedure. But at about day 10 to 12, she got severe diarrhea, and on postmortem, she had what appeared to be pseudomembranes in the literature. In 1935, first description of C. difficile in stool in healthy neonates, and at the time it was named Bacillus difficilis because it was difficult to isolate in culture. And in 1978, really the turning point when Clostridum, the bacteria Clostridum, was associated with pseudomembranous colitis. They took stool and broth culture from patients, 4 patients that had pseudomembrane colitis, and they were able to take that supernatant, introduce it to mouse, cause cytotoxicity and enterocolitis in hamsters, I mean. And that they could reverse that by neutralizing with C. sordelii antitoxin. So a very important time in the history of C. difficile. And 2005, more recently, identification of a particularly virulent strain that I'll talk about, NAP1 B1027. So this is really the problem that I think all of us have encountered more recently, and what we've seen in the last 10 to 15 years is a dramatic increase in hospital-acquired, nursing home onset C. difficile, which is costing a lot of money and causing a lot of morbidity and a lot of mortality and deaths. I'm going to try for 1 second to figure out how to, okay, good. Got to figure out how to get that working. And we've seen over the same period of time increases in US and UK associated death rates from C. difficile infection. And that in 2006, that the death rate from C. difficile infection was 4 times that of MRSA and 6 times that of all enteric pathogens combined. So really a very, very big problem. So this map of the United States kind of highlights inpatient hospital cases in 2009, and we're sitting at about 13 per 1,000 patients in Utah, which is about in the mid-range of distribution of cases in the United States. With quite a few more cases, I'm going to go back, quite a few more cases occurring, up in the Northeast and places around the Great Lakes. I'm not sure why that's the case. So what is it about C. difficile that causes symptoms and causes disease? Well, C. difficile disrupts. Well, you get disruption of this normal colonic microbiome by antibiotics. And you get proliferation of Clostridum, which may have been there or may have been picked up from the environment. And this Clostridum releases toxins that cause enterocyte or colonocyte damage, leakiness of tight junctions, and you get this sort of immune response that comes up, and ultimately you develop inflammation and cell death, and you develop the pseudomembrane up here. And patients become very, very symptomatic. So I won't talk much about this other than there is a well-conserved area, the pathogenicity locus, right here that encodes 5 genes, 2 of which, toxin A and toxin B, are really responsible for the problems we see with C. difficile. So how are patients getting this? Well, a lot of them, the patients that get in the hospital, they walk into the hospital and they're C. difficile negative. And they are exposed in the hospital to toxigenic and non-toxigenic strains. And that occurs because of us or other healthcare workers, or that aren't washing their hands. And these rates have decreased over time. But if you are a patient that is unlucky and you're exposed to C. difficile in the hospital, if it's non-toxigenic, you're just colonized. If it's toxigenic but you have an IgG response, you're asymptomatically colonized. But it's these patients that are unlucky that are exposed to toxigenic forms that are failed to mount an IgG response become symptomatic. C. difficile patients. So a little bit about this particularly virulent strain of C. difficile, first identified in 1984 in Pittsburgh, then through Canada, and then went worldwide. And this strain is associated with emergence of fluoroquinolone use and resistance. And what this strain does that makes it particularly virulent is it makes a lot of toxin. 18-fold more toxin A and 23-fold more toxin B. Now, it occurs because of mutations in a negative regulatory gene that increases toxin production, also increases binary toxin production, a third toxin, which augments the effects of toxin A and B. And what happened with this strain that you hadn't seen previous to this is that this strain affects patients who are less often on antibiotics or have an exposure, who are more often healthy, peripartum women. Some patients have IBD and cirrhosis, and more of these cases are community-based cases. And unfortunately, with this particular strain, the disease is quite a bit more severe, with more cases of megacolon perforation, colectomy, and death. And this map, sort of in 2007, published, shows sort of the distribution and report of states with this particular strain, and we've seen that strain here in Utah. So what do we see histopathologically from C. difficile? Well, what I ask them to look for when I have IBD patients that I scope, or I've scoped someone with diarrhea, is I want them to look for this sort of volcano lesion, which is suggestive of C. difficile infection. You develop these areas of surface mucosal ulceration, and you get sort of this exudative area here of inflammation and fibrin, and then this is a volcano lesion. And then ultimately, sort of the last stage is formation of this fibrinous cap, which is what we see on endoscopy as a pseudomembrane. Can you start that? So this is classic C. difficile when we scope a patient. You see these sort of raised yellow, tan, sometimes they're green, looking pseudomembranes. Almost looks like pieces of adherent corn or something. Now, some patients we see with C. difficile. I heard some people out there like, that's just gross. But some patients with C. difficile, when we scope them, they actually look pretty normal. And I don't really see anything but erythema. But when you see pseudomembranes like this, it really is C. difficile. All right, you can stop that. So what are risk factors for C. difficile infection? Well, there are host factors, factors that disrupt colonic flora, and factors that increase exposure to spores. Host factors, age older than 65, comorbid disease, inflammatory bowel disease, as Dr. Valentine has talked about, and peripartum females. Factors that disrupt the colonic flora, antibiotics, by far and away the most important. But immune suppression and chemotherapy, that's increased risk. Gastric acid medications, or PPIs. The FDA came out with an advisory regarding PPIs and C. difficile a few years back. Manipulation of the GI tract from surgery, obstruction ileus, these are all things that increase risk. We're more often exposed to C. difficile spores if we're taking antiperistaltic medications or prescribing lots of those. Contaminated food, water, soil, pets. I had a patient that came in with C. difficile that she swore she got from her dog, and that her veterinarian had C. difficile from the same dog. I didn't call the vet and talk to him about that, but apparently her and her veterinarian had both developed C. difficile after a diarrheal illness in her pet. Hospitalization and, of course, staying in a long-term care facility increases the risk. So this is just a study that showed that the relative risk of PPIs are about 3, and H2 blockers about 2 for development of C. difficile. So to shift over to treatment, we're always looking for new prevention and treatment algorithms, new ways to treat this. And I will talk about briefly about probiotics, quite a bit about antibiotics, briefly about toxin binders, less about IVIG and human monoclonal antibodies. And I don't have on here, but I'll talk quite a bit about fecal microbiome transplant or fecal transplant for C. diff. So what are basic principles of therapy? I think first and foremost, discontinue, if any, antibiotics whenever possible. Someone's on concurrent. And that stems from studies that show delayed resolution of diarrhea and increased recurrence rate in patients who were concomitantly treated with C. diff or with non-C. diff antibiotics at the time of their C. diff diagnosis. So the next step in therapy is to test stool, make a diagnosis of C. diff and its toxins. So when is testing recommended for C. difficile? Well, you have to have diarrhea, unless, there's caveats to that, but diarrhea, more than 3 non-foreign bowel movements in 24 hours. Unless a patient has ileus, or the caveat to that also is a patient comes in and they said, well, I had C. difficile 6 months ago, and I swear it's back. When I hear that, it's like, okay, I'm testing you again. I don't have to ask another question, because if you're wrong, you look like a chump, you didn't even listen to the patient. They knew it was back and you didn't do anything about it. So if a patient comes back and says, it smells like C. diff to me, it feels like my C. diff, then they should be tested. Clinical relapse after a treatment regimen, or I would also say a patient who received treatment and never improved after their treatment regimen should be tested. Testing is not recommended, obviously, for people who do not have symptoms to document cure, because, importantly, patients may carry a toxigenic C. difficile in their stool for months and not have symptoms. And our testing these days is getting that good that it could detect that. And repeat testing during the same episode of diarrhea. In preparing this talk, I talked to the main guy at IHC Labs down at Central Lab in Salt Lake. And he also said, make sure you tell them that we're not getting 3 repetitive studies anymore, like we have in the past with EIA antibody testing. So it's not appropriate anymore to order 3 studies on 3 separate stools over 3 days. So let's go over briefly what tests are out there. The toxigenic culture is the gold standard. You take stool, you culture it, you isolate C. difficile, and you run cytotoxin detection studies on it. The problem is, it has highest sensitivity. The problem is its turnaround time and expense, and we don't always have the luxury of waiting 2 days to a week or longer to get results back. The cytotoxin assay, you take stool, you do cytotoxin detection on it, sensitivity 67 to 100%, and the turnaround time's okay. Not a first-line test. Toxin A and B, ELISA, has fallen out of favor because it's too insensitive and no longer recommended. This is what we used to have. This is the test that we had where you would test one, and on the 3rd one it was positive. And you never fully believed the test you had. And that's not run any longer. So let me talk about the tests that are run now. There's a GDH antigen and toxin detection test. What they do is they take stool, they check for glutamate dehydrogenase, which is in both toxigenic and non-toxigenic forms. If it's positive, they know you have C. diff, but they don't know if you have toxin producing C. diff. That requires another test, which is usually an antibody test, a PCR, or a DNA test. And that has increased the sensitivity. And then lastly, there's the nucleic acid amplification test, PCR or LAMP DNA testing. And again, this is a very rapid test with high sensitivity and high specificity. So what is run around here in the hospitals that we work at? They're running currently the Illumigene, which is a LAMP DNA assay, at McCady Hospital, all IHC facilities. As if you order C. difficile, you write an order for C. difficile, this is what you'll get. An Illumigene LAMP DNA assay. If you're at Ogden Regional Medical Center, affiliated with Columbia Healthmark, I think, Davis Hospital, which is ISIS, I think, what you're going to get is a C. diff quick check test complete, which is the GDH antigen, toxin A antibody, toxin A and B antibody detection. So the reported sensitivity, specificities, negative predictive values are listed. This is from the company. Now, I tried to get the information. I wanted to know. This was difficult to obtain. Of course, I made lots of phone calls, and I didn't get anywhere. I wanted to know, how well do these studies do here amongst our population of patients? And they said, well, I'll get back to you. Can you call me between 10 o'clock and 10:30 on Wednesday? No. I'm scoping. That's a hard time. So I couldn't get that information, but what is reported is with the Illumigene study that's done through McKay and IHC, Intermountain Healthcare, a negative predictive value of 99.1%, sensitivities in the 95%, specificity in the 95% range. So if you have a negative test, with the study, it's very likely to be a negative test. The C. diff quick check has sensitivities 88%, specificity 99%, with a negative predictive value very high of 98 and a positive predictive value very high of 95%. So, important that if you order a test at Davis Hospital, Ogden Regional Medical Center, and it's a GDH and an antibody, they'll report two different results. The GDH was positive, or antigen was positive, and the cytotoxin was negative. That's not a toxin-producing strain. It's important to sort of say to yourself, well, okay, they have C. diff, but they don't have a toxin-producing C. diff strain. So you have to investigate other causes for their diarrhea. Or if you're still concerned, this is C. diff, they had antibiotic exposure, go to a toxigenic culture or a C. diff culture, or go to LAMP DNA assay or a PCR-based study and make sure. So, next step in management is to initiate therapy, either empirically or after confirmation of diagnosis, and that kind of depends on how sick your patient is. If they have the right clinical history, I start an antibiotic if they have that kind of clinical history, because often it's Friday afternoon and I'm not going to get a result back very easily, and I'm sending them out the door with an antibiotic. So what pharmacotherapy do we have? Metronidazole, vancomycin, fidaxomicin, some other drugs that are not FDA approved that I'll talk about briefly. And of course, supportive therapy. So there was a consensus guideline published in 2010 by the Infectious Disease Society of America. And they recommend stratifying disease and then going from there. Mild to moderate disease, starting with metronidazole. Severe and severe complicated disease, using vancomycin. So, what have we seen over the last 10 to 13 years? A treatment failure rate with metronidazole approaching about 20%, and recurrence rates with vancomycin and metronidazole of about 30%. So what do we do with severe patients? Mild to moderate patients can start, if they've a new diagnosis, they can start with metronidazole. But if they're severe patients, they should go right to vancomycin, 125, 4 times a day for 10 to 14 days. So what are markers of severe disease? Well, these are patients that come to the office that are going frequently, have low-grade fevers or maybe intermittent fevers, white counts elevated. Many of these patients are ending up in the hospital. I mean, if I had a patient come in, they were going to the bathroom 10 plus times a day and were febrile and had C. diff, or I thought they could, I'd probably put them in the hospital. These markers on the right over here, ileus, megacolon, abnormal CT scans, ascites, pseudomembranes, when you scope them, these are all markers of more complicated disease and organ failure. So, of course, anytime someone can, there's lots of research actively trying to figure out, are there ways that we can predict these patients, the ones that are most likely to develop a severe outcome from C. difficile. This was a abstract poster published at DDW 2 years ago of 630 patients. And they deemed a severe outcome ICU admission, colectomy, or death. And they looked at 3 variables: age greater than 70, a creatinine greater than 2, and a white count greater than 20. And of course, if you had all 3 of these, your risk of having a severe outcome was higher. So until they come up with one of these validation clinical scores that has a predictive accuracy closer to 95%, and something that I can plug into a phone, a smartphone of some sort, and remember all the time, it's harder to use these, but it also illustrates that there are factors that people are looking at, trying to figure out how can we predict these sick patients, who they are, and get them appropriately triaged and treated. So, if you remember, I said severe patients you treat with vancomycin, and this is why. Because they compared head-to-head vancomycin and metronidazole in a randomized prospective study published in 2007 and stratified for disease severity and used many of these similar markers, age, febrile patients, and elevated white count, and pseudomembranes, ICU admission. And they found that patients who had more severe disease did better with vancomycin and metronidazole. Significantly better, and in mild to moderate disease, vancomycin and metronidazole perform similarly. So again, if you have a severe patient, and I would argue as well after hearing Dr. Valentine's lecture, an IBD patient, the data should be that you should treat with vancomycin orally. So what about severe complicated patients? These are the patients that are often in the ICU. They should be on vancomycin, 500 milligrams 4 times a day, PO, NG tube, and metronidazole, 500 milligrams IV every 8 hours. And they should be monitored intensively for factors that predict death, that elevated white count, increasing creatinine, elevated serum lactate. And these are patients that should have an early surgical consult and consider adding other antibiotics. And there's not good data to support that. And is there a rule for a fecal microbiome transplant in these patients? And we don't have great data on that, obviously, either. So, moving on to talk about recurrent C. difficile infection. And this is really what hits home so close to us because we see this in practice every week. So, up to 35% of patients will develop recurrent C. difficile infection, either because they relapse or they're reinfected. Many of these patients, it's tough to tease out sometimes, develop post-infectious irritable bowel complaints after C. difficile. They come in, they say, I don't feel the same. I had C. diff, whatever it was, and I've still got diarrhea and loose stools and cramping and urgency, the whole thing. Of these patients that recur, up to 30%, of that group, up to 60% will have a second recurrence. And 3 to 5% of that group will have 6 or more relapses. And those relapses may last for a long, long period of time. And you might say, well, what is causing relapse? You might think, well, it's resistance to the antibiotics. But it's not. And there's important reasons why we think that this is happening. This graph on the right shows this person right here at the bottom with recurrent C. difficile diarrhea, who is the worst place to be with recurrent C. difficile because they fail to amount to develop a serum IgG antitoxin response. So their immune system is not making IgG antitoxin. This red graph here represents a patient that had a single episode of C. difficile but amounted that immune response. So this is a study published in 2008. And this talks about the importance of the fecal microbiome in recurrent C. difficile infection. We know that antibiotics alter the microbiome, that is the entirety of the bacteria, the bacterial products, the metabolites of the bacteria in our colon, that antibiotics alter that microbiome. And this graph on the right, what it shows is it shows control patients with C. difficile, in blue, in red, initial C. difficile patients, and in green, patients with recurrent C. difficile. And this is the number of phylotypes, the number of bacterial types in the colon. So, with recurrent C. difficile infection, antibiotic exposure, the number of phylotypes are suppressed. And the graph on the left shows the types of bacterial phylotypes there are. And so, antimicrobial therapy, antibiotics perpetuate loss of this resistance, this colonization resistant, because vancomycin and other antibiotics suppress bacteria in stool. and that patients with C. difficile infection have decreased richness of this bacterial phylotype, and that bacteroides and firmicutes are reduced in patients who have multiply recurrent C. difficile infection. So how do we manage these patients? I must say there's no universally recommended, accepted treatment algorithm. That recommendations are not evidence-based, and that treatment failure before 2003 was not quite the problem that it is now, and up to a third of patients fail treatment. And that vancomycin is bactericidal for almost all gram-positive aerobes and anaerobes, alters the normal flora of the colon, and there's problem with vancomycin and emergence of resistance to VRE and MRSA. So vancomycin is not a drug that we want a patient to be on for a long period of time, but unfortunately that's what's happening for a lot of these patients. So how do you manage these first recurrence? Well, if they got metronidazole and they have a recurrence, the next step is vancomycin. If they have a second recurrence, the next step is a prolonged oral vancomycin pulse and taper regimen. Or you could go to fidaxomicin. I'll talk about that briefly in a moment. It's a new drug approved, I think year before last, for treatment of C. difficile. Third and subsequent recurrences, prolonged oral vancomycin, fidaxomicin. You could try rifaximin, nitazoxanide, or a fecal microbiome transplant. This was a tapering regimen, pulse regimen, for C. difficile that was published a long time ago and has never been repeated. But this has sort of became the standard. And this kind of goes to show that we do not have great evidence-based data to support what we do for these patients with recurrent disease. This was a really, really old study. But in the way we taper is similar to this, is that we give 125 QID, we decrease it to TID for a period of time, BID for a period of time, and then we pulse it every 2 days for a little while and every 3 days. So we talked about prolonged metronidazole vancomycin therapy. There are other antibiotics, fidaxomicin, as I said, that was just approved for C. difficile a couple of years ago, that was briefly talked about this morning by Chris Beliga in his infectious disease update. Fidaxomicin was compared head-to-head to vancomycin, and it was shown to be equally effective. It's not any better, but that it decreases the recurrence rate of C. difficile infection. The problem with fidaxomicin, and I've used it only once, is that it's expensive. And the coverage on it's a tier 3, and by this point, patients are, my experience has been, they just refuse to take another antibiotic because of expense. There are toxin-absorbing agents, cholestyramine and tolevimir, with sort of variable data that helps. Immunotherapy with IVIG. I have one patient in the past I treated with IVIG, the patient that got C. diff from her dog, and she did fine and cleared it. Probiotics, Saccharomyces. I think we've all heard of Fluorostar, using that after someone develops C. difficile infection has been treated. There's some data to support that that's helpful, but not universally recommended. And then the fecal microbiome or fecal transplant for C. difficile that has become quite a bit more popular these days. So that's what I'd like to kind of focus the last part of my talk on, because about a year and a half ago, a patient came to me who had had several episodes of C. difficile, and antibiotics weren't helping, and she was pretty sick. And I had received, it was one of the journals I had published a paper on it. I thought, well, this is something I can do, and I did it. And it really helped this patient, and that's kind of where I started doing these. But what do we know about fecal transplant is mostly what we hear about in the lay literature, which is, I can't believe someone's doing this. And I'm going to show a clip here and this gives some idea of how people feel about fecal transplant when they hear about it. It's because they've been exposed to it in this sort of way. We'll need to hear sound on this too, if you can play it.
Ellen was so sick she couldn't eat for almost a year, Dr. Stuart Dunn at Sinai Hospital was willing to try something radical, a fecal transplant.
It's like a heart transplant, but poop.
Actually introducing it into the patient. So we had to go through the mouth.
Doctors can now write you a prescription to eat and live.
There's something wrong in this country.
Okay. So the response I get when I tell people about this is sort of like this, you know, I can't believe this. I mean, am I hearing this right? You're going to transplant stool from someone else to me. And so there is good, there's not great data to support, and there's not a lot of data, but I wanted to kind of outline all of the data there is to date that I know of on fecal microbiome transplant and talk about the 10 cases, well, 13 cases I've done in the last year. So what is the rationale for doing this? There is a whole new line of research in human microbiome research. If it's the skin, the gut, the respiratory, the vaginal, the urinary microbiome, and how that microbiome plays a role in health and disease. And so I'm focusing just on the colonic microbiome. But there's incredible literature coming about and research that's being done to show that the bacteria that live in, not only bacteria, the viruses, every pathogen that lives on and around us does play a bigger role than any of us have ever imagined. So what's the rationale for a fecal microbiome transplant? To reestablish the integrity and diversity of the intestinal microbiome, to take a healthy microbiome and transplant it to an unhealthy microbiome, restore this resistant to colonization from C. difficile, with the hopes that you can avoid prolonged repeated courses of antibiotic therapy which perpetuate the problem, encourage resistance. And this has been around for quite a long time. 4th century, Ge Ji-hong first reported case of food poisoning and diarrhea treated with human fecal suspension. This has been around, this idea of transplanting stool has been around for centuries in cattle, in the veterinary world, to treat and cure problems with diarrheal illness, other illnesses in cattle and in horses. In 1958 was the first known reported case of fecal transplant for pseudomembranous enterocolitis treated with fecal enema. 1983, first fecal transplant for confirmed recurrent C. difficile. 1991, fecal transplant through an NG tube, which to me, you know, I mean, think about that. You get fecal transplant through an NG tube and you get an ileus and you vomit. But, you know, these studies, lots of these studies have been done. 2000, fecal transplant via colonoscopy. In 2010, self-administered enemas were published. These studies were published. So, the protocol. I did the first one, had the patient tested donor, and then some things started happening. I got a phone call from Intermountain, a representative, saying, well, you're doing this, we want to make a protocol. And so they took a protocol, they made a protocol through Intermountain Healthcare, and they did this under the auspices of their Infectious Disease Council and some other people, and came up with a protocol that mirrors the protocols that are out there right now in clinical trials. And the qualification for a fecal microbiome transplant under protocol is recurrent C. difficile. You have to have recurrent. I mean, it's not a first case thing right now. And you have to have had an adequate antibiotic trial. And an ID consult, although recommended, is not mandatory. So an adequate antibiotic trial is sort of in the eye of the beholder. But basically, you've had to have been on metronidazole, vancomycin, and it failed those at least twice. And if you haven't had a vancomycin taper, you should get that if it recurs. And you could argue to try fidaxomicin, but my experience has been again, that fidaxomicin is expensive and it's hard to get. Patients by that time are just fed up with it. So you choose a donor. Usually it's an intimate partner, thinking that, you know, they're more likely to put up with this. I mean, if you go to your brother who lives out of state or something, or, you know, down the road, I mean, he's going to say, are you kidding me? But intimate partner, first-degree relative, household contact. I put other up because at the University of Minnesota, where they've been doing a lot of this research, they actually have a fecal donor pool who've been screened, and they get screened every 1 to 3 months, and they donate stool. It's spun down, prepared, and frozen up, and they pull the bag out, and they do the next case. You have to test the donor. We talk to them, the donor, we screen them. No antibiotics for 3 months, no history of current or recurrent diarrheal illness, high-risk behaviors, cancer, IBD, immunocompromised, metabolic disease. So we ask them about high blood pressure, high cholesterol, diabetes, all of those things. The reason, the rationale behind that is that are we transplanting a risk of metabolic disease from one person to the other? Because a lot of research right now they're doing is sort of deciding, is there something in the stool that's making one person heavy versus another who's not? And so those kind of research studies are ongoing right now. So these are questions we ask the donor. It's recommended that the donor be tested for enteric pathogens. We test for hepatitis B, C, HIV, syphilis. Now, we haven't always tested for the stool until very recently because there's very important problems with this. Our labs cancel our studies if the stools are non-liquid. So we have to call them and say, don't cancel this. This is actually a screening test for a fecal transplant. Now, why do they cancel a study that's non-diarrheal? Because the likelihood of actually having a pathogen if you don't have diarrhea is very, very low. That's why, you know, I've gotten back, I sent a patient to the, you know, down to the lab, turn in this stool study, and what happens? It's canceled. My stool was hard that day. I'm like, you're not supposed to do this. When you go to the lab, you know, you're supposed to have diarrhea that day. But they will cancel it. And so we have undertaken, and recently we test everybody for enteric pathogens. Why? Because we don't want to transplant crypto or something else to our recipient. So recipient gets, the recipient or the patient who has recurrent C. difficile discontinues antibiotics 2 to 3 days before the procedure. They get a large volume colonoscopy prep the evening before. The idea thinking, well, we're going to push a lot of that C. difficile out, hopefully. The donor gets a general laxative the night before. They always ask why. Well, because we need you to go on demand. You know, you can't like get cold feet on us because I have a schedule to keep. You know, we need you to be here at 11 o'clock with a sample. So they pass stool into they give us a sample. We bring it to the lab. My lab techs, who love me for doing this to them, they prepare it. You know, the only thing they're not using is a biohazard vent, but they're pretty much otherwise geared up for this. You know, full attire. The donor stool is suspended in normal saline, filtered. We want it liquid. And then I do a colonoscopy, deliver 400 to 500 cc's of liquid stool into the TI and right colon. I put it there so that they're not going to the bathroom before they get to the recovery room. And the first couple I did, I put it all throughout the colon, and they were already going to the, you know, it was all coming out, you know, within minutes. And then they wake up and they're like, geez, this is the best thing that's ever happened to me. And so, recently, they've sort of started to look at, well, what works best? To install the stool in the right colon, how much do you put there? And from what I've read, it looks like the more stool you put, the better. And those studies have not been rigorously performed, but that's the sort of thought right now. So 400 to 500 cc's is what I do. Drawbacks, aesthetically unpleasing. Everyone, just jaw hits the floor if they haven't heard about this before when I have mentioned it to them. They're surprised that we do this. There is no reimbursement or reimbursement issues right now. Cautions, of course, potential to transmit disease from one person to another or to transmit a metabolite of ingested food. Say that your recipient has a peanut allergy and your donor ate peanuts the day before. Pros, decreased emergence of antibiotic-resistant bacteria. It's inexpensive relative to what may be months of treatment with vancomycin and rapidly effective. within hours to days. So these two slides are summaries of all reported cases to date, going back to 1958. And these numbers are small, and they need to be a lot bigger. And the mode of delivery or the place of delivery, upper GI tract in many of these cases was through an NG tube. Lower GI tract, some of them were enema, other were colonoscopy or scopes. And the cure rate is reported on the right. You can see from 2010 to now, there has been acceleration in the number of these studies that have been published. If you add up the cure rate amongst all these studies, it's at about 90%. So if you pay attention to this number here of about 400, 500 cases have been reported, that is not enough. We need a lot more of that to really know how effective this is. And we need rigorous studies. So what has been my experience? Well, these were the first 10 cases that I did. And you can see their age. Between 28 was the youngest and 80 was the oldest. I had one gentleman that was an inpatient, failing to improve, had been in the hospital for 2.5 weeks with severe diarrhea, had tested negative after treatment with vancomycin and flagyl, but still had severe diarrhea, did a scope, looked kind of like pseudomembrane colitis still, and did a fecal transplant. Of these 10 patients, 9 had clinical improvement to their baseline symptoms, or to their baseline. And that improvement, I list in number of days, really depended on when I got a hold of them. For some of them, because some of them didn't come back for 2 or 3 weeks. But as best as I could tell, some of those patients had improvement within days of a fecal transplant. The 10th patient I did, patient JA, had no improvement whatsoever in clinical symptoms. Now, these patients weren't retested after, because I don't retest because that can be misleading. They can harbor toxigenic C. difficile for quite a long time. Of these 10 patients, I had 3 patients that tested positive for C. difficile and had recurrent symptoms. And of those 3 patients, 2 of them were retreated successfully with 1 course of antibiotics, vancomycin in 2 of those cases. That 3rd patient, I wasn't sure if he got better or not because we had no follow-up on him. He was the patient that was the inpatient. And what happened to him, interestingly, he's in the hospital, treated him, did a fecal transplant, went home to the nursing home to recover from all of this hospitalization. He was 67 years old. And the nursing home called about 2 weeks later and says, he has C. difficile again. And I said, well, why are you testing him? Because he told us yesterday in clinic that he was feeling perfect. They said, well, because it's our protocol to test everybody in our nursing home if they have C. difficile. So because he had it, he was already on therapy from the nursing home. We never quite heard how he did. So since this time, I've done 3 other transplants. 2 of those patients had had clinical improvement in symptoms, resolution of symptoms. The 3rd I saw 2 days ago, no improvement. And she's getting retested. She had no improvement after fecal transplant 3 weeks ago. So what does, and if I have just a minute, I think I do, you'll tell me how close I'm getting? Okay, all right. So what does donor stool do? And these are 3 very, very, very interesting slides to me that were given as a presentation last year at DDW by Co-Roots. He's the lead investigator out of Minnesota, where they're doing a lot of this research. And so this is a patient, a 67-year-old patient with multiply recurrent C. difficile and ulcerative colitis. And you can see that this is the fingerprint phylotype graph of what the donor looked like. They had predominantly bacteroidetes and predominantly firmicutes. And this is the recipient with C. difficile prior to transplant. And you can see that their microbiome fingerprint is very different than donor. They're predominantly this proteobacteria and firmicutes, but they've lost bacteroidetes. This person gets a transplant, and this person's fecal fingerprint, as I call it, looks almost identical to the donor. But what's interesting about this is that it persists at 25 days, 65 days, and 128 days and looks very similar to the donor's fingerprint. So this person did well. This is another example, same sort of idea, 76-year-old woman recipient who had lost bacteroides, got a donor transplant, and her stool fingerprint looks very similar to donor transplant, and that's persistent for 112 days. And this is a patient, a 74-year-old woman who had multiply recurrent C. difficile infection that got, and you might be able to see this, what happens, so that here she is here, she of course gets a donor transplant, her stools look like donor, and then boom, at day 30, she gets antibiotics for urinary tract infection, she got metronide, well she got Bactrim, got C. difficile, and then retreated. So this raises interesting questions that I would like to know kind of what happens at 6 months and a year. Does their stool remain very close to the bacterial content of the recipient? What we don't know is what does this mean going forward for that person's colonic health? Is there some sort of genetic susceptibility or not, or disease susceptibility that could be transferred? But interesting studies. So when to perform a fecal transplant for recurrent C. difficile? For recurrent refractory C. difficile, I think yes. Because the antibiotics aren't working. For severe disease, patients with severe disease, arguably, yes. As a first-line therapy, don't know. And we really need more studies to answer this question. For post-infectious C. difficile IBS, post-infectious IBS, irritable bowel syndrome, we don't know. For C. difficile and ulcerative colitis, or ulcerative colitis alone, we don't know that. But these are all questions that are being answered, that are being asked. So right now, there are 6 studies recruiting on clinicaltrials.gov looking at fecal transplant for recurrent C. difficile, comparing against vancomycin. So there's active research. Other areas of investigation actively, fecal microbiome transplant and IBD, irritable bowel syndrome, for treatment of constipation, diabetes, obesity, chronic fatigue syndrome. This has been done for chronic fatigue, metabolic syndrome, insulin resistance, autism. There's questions regarding donor and donor screening, route and means of administration. There's safety issues that need to be answered. There's issues regarding can you artificially produce stool, encapsulate it, and give it to a patient. That would require that we know what is in stool and what is there that actually makes a person better. Those are things I think that in the next 20 years we'll have an answer to. Now, a major roadblock. This is a letter sent from, and I didn't catch her name, from the director of the biologic unit at the FDA to the president, I believe, of the AGA 3 weeks ago. And she said, "It is my opinion that fecal microbiome transplant is a biologic agent used to alter disease state, and therefore you need to apply for an investigational new drug application." So, my experience with this was at the University of Iowa back in 2004, 2005. I was there when our research group there in inflammatory bowel disease they were the principal investigators using whipworm, pig whipworm, to treat Crohn's disease and ulcerative colitis. And they had finished their phase 2, I believe, study and were publishing data. And the FDA wrote a letter and said, "You are no longer allowed to do your studies unless you apply for a new drug application." And that shut it down in the United States for years. I went online, looked at their new drug application. It's 19 pages, has 8 supplemental forms, and some of those forms have 45 pages. And so they did say in this letter that, if your patient has an emergency case by case, we'll deal with that. Well, I don't think there's any way they can deal with that in an emergency. So where does that leave IHC? IHC has decided in an email I got yesterday that they are looking into this. They don't necessarily agree, and for now they're looking at it with outside counsel. Because if you give, if you secede, if you give them this sort of power to do this, then they'll take it and you can never come back to it again. So they don't know. IHC doesn't know what they're going to do. I was told I can't do it anymore. This is often how patients come to me with multiply recurrent sick patients with C. difficile infection. And after fecal transplant, my experience has been uniformly successful, much more happy. If my wife knew I put these pictures up, she would kill me. Thanks. Yeah, question here.
What's wrong with dairy or soy-based yogurt that has several species in it that normally get a
So the question was, what about some of these soy-based other yogurts or dairy-based probiotics, essentially, that may be useful? Now, clearly, I don't think there's harm by using those agents, but for C. difficile infection, I'm not sure that it's very helpful. Basically, the idea is that you're putting good bacteria in your colon, and that may somehow improve disease state, and I think that may be beneficial in some situations. But for C. difficile infection, it's the right type and the right amount of bacteria to essentially replace a microbiome and establish health. Problem with just a small cup of yogurt is you're not getting enough, in my opinion. Oh, a question here? Yeah.
Am I wrong? I've seen the rise of C. difficile over the last 25 years. At the same time, everybody's been on a PPI or an H2 blocker. And you wonder, the main function of acid is to prevent infection. And many people who go overseas, they want them to stop their PPIs. Is that true, or is that way off? Or do you think that has helped the growth of C. difficile? Because I never heard of it when I was in medical school.
Yeah. And so you raise an important concern, and I think that's why the FDA put out an advisory that I think there is data to show that PPIs can increase that relative risk of C. difficile infection. And it's interesting that it correlates, the rise of PPIs over the last 20 years, 25 years sort of correlates to this. I don't think that's not obviously the entire cause of this emergence, but it's an important one, I think. And that's why I tell my patients, if you're on a PPI or an H2 blocker and you don't need it, we need to stop it. Not only that, there's issues with metabolic bone disease and calcium, vitamin D absorption issues, and also may increase the risk of bacterial overgrowth, PPIs, chronic PPI use. And so if your patients don't need it, they should stay off of it. Yeah.
I was just going to say, new human babies, their guts are colonized, I assume, by eating dirt and mom's finger, mom's breast, pacifiers, that kind of thing. Has that kind of thing been looked at to recolonize adult humans?
Well, what's interesting is that in babies, they have the highest number of C. difficile bacteria in that first, several weeks of life. And so that, I don't think that's been looked at. The problem with that is that you may be transmitting risk of C. difficile if you did colonize from babies. But that's a very formative time, and they're doing lots of research about that. At that moment in life when you develop that microbiome, is it somehow being altered in some way that's increasing disease risk?
So, the FDA is always difficult to deal with. On a phone conversation with them last year, I took it to the ridiculous extreme. I asked them, so if I wanted to use a particular diet to see if it helped patients with Crohn's disease, you told me I had to get an IND. And they said, yes, because you're intending to treat a disease or symptom, and your diet's not approved for anything. So if you want to take it to the extreme, they can say that each patient's flora is different. You're going to need an IND for each donor, because all of our stools are different. So hopefully they won't do that, but I could see them going in that direction too. Or store some for yourself.
You need to store that stool for yourself, you know. Yeah, it's a frustrating thing because, I mean, it hits close to home. I have 3 patients right now that are trending towards needing this. And what do you have to offer someone who is already on a vancomycin taper? You have fidaxomicin, which is expensive and not any better than vancomycin. So it's a frustrating thing, and especially when I'm called and said, you can't do this here anymore. And I think, well, why don't we just apply for a new drug application? Well, I pull up the application online, I'm gonna have, it's just not feasible for me. But so I would entertain the idea of going into a clinical trial with someone to get this up and running so we can use it and not worry about it with the FDA.
It sounds like the FDA is going to shut down medical research in the United States, but if they continue on that trend. But I guess my other ideas were, again, I mentioned this to Chris earlier, but the bacteriophage idea of maybe a particular type of phage that would attack C. diff that could be given in an enema. That's one idea. And the other thing I had was a question. You mentioned giving IgG. Was that a specific antitoxin, or was that just?
It's just pooled IG.
Another idea might be to go back to the original 1978 study and see if we could give a specific antitoxin against that the C. diff that produces the increased amounts of toxin. But again, FDA will shut that down too.
Yeah, darn FDA. Any other questions? Oh, we have one here.
I'm curious about how diet and the body pH relates to the C. difficile flora.
Well, to the colonic flora, well, diet is important. I don't know that I know right off on that and how pH. I don't know if you have any insight on diet and pH. That's a good question. I'm not sure that I know that I can answer that for you.
I interned at the University of I did my senior rotation up in Eau Claire, Wisconsin in the fall of 1962. We had a patient with chronic diarrhea, and we had some wild German residents. They gave him a shit sandwich. They basically collected stool and gave him a fecal enema. 1962. Legendary since that time, and now it's come to pass.
Yeah, thanks for sharing that with us.
The joke at Wisconsin for years, the crap sandwich.
Very good.
There have been studies about diet across different nationalities or different countries. You know, certain Asian diets might be heavy in rice, and others are heavy in wheat, or any other diet things that correlate incidence of C. difficile infection.
I'm not aware. I have not seen that in the review I did. If diet has a role across the different diets, if there's a role in C. difficile, I haven't seen that. But that's a good question. Yes?
Two questions. Why don't we investigate the use of probiotics with multiple strains? And the second question, how do we know that when we do all these scopes, we're not introducing bacteria like C. diff? I know the stuff they soak them in is supposed to kill everything, but doesn't.
Yeah, maybe answering that last question first is, how do we know we're not introducing other bacteria? Well, the methods we have to sterilize scopes are very robust. And the thought of introducing another organism is that risk is very low, is my thought. Very, very low at the time of colonoscopy. It is the last thing I do before I leave the lab that day. And the very reason for that is because I don't want to transmit that patient's risk to anyone else. So we don't do a fecal transplant the first part of the day, we do it the very last part of the day. Remind me your first question. It was about
possible investigation of the use of probiotics with.
That's right.
You can go to Good Earth and get a very good probiotic that's got like 50 some odd strains in it.
Sure, and again, I think there's been a lot of research into this. The problem is that what strains are beneficial? And the amount of bacterial exposure per pill or per dose. And I think that you're onto something that's very important in the future. It's just that we're not there yet because we don't understand what's in stool and what's actually improving the situation. What is in the colon? What are all the bacterial types there, and how do they interact and cause or modulate disease? So I think that's where the future is developing a probiotic that you can encapsulate, a stool-formed probiotic that replaces what we're doing now, which we'll look back on and say, geez, that was barbaric. I mean, that was just plain sick. So I think you're onto something very important. Right now, we have no data, not a lot of data to support that probiotics are very helpful for primary treatment. Now, maybe for decreasing recurrence rates, but now we just don't have that information. Okay.
Any recommendations on someone who's had C. diff, and especially with a recurrence, who comes up with another infection that you've got to treat? I find that I'm a little bit gun shy now. I've got a lady who's had a recurrent C. diff, and she had a UTI just recently, and now I've got to decide what to put her on.
And there is no published data to support what to do there, but the expert opinion is that those are patients that should be prophylaxed with vancomycin, probably low dose. If they've had multiply recurrent C. diff and then they got, I don't know, pneumonia or urinary tract infection, need antibiotics, those are patients that should probably take low dose Vanco 125, QID or TID during the length of that time if they're on antibiotics. But that's only expert opinion. All right, thank you.